Welcome to this video conference coverage from the 2024 American Society of Clinical Oncology annual meeting in Chicago, Illinois, and the European Hematology Association Hybrid Congress in Madrid, Spain. In this series of 5 episodes, our expert hematologists, oncologists, Dr. Saira Ahmed and LaCasce will review the most recent data for the treatment of patients with non-Hodgkin's lymphoma, including diffuse large B-cell lymphoma, follicular lymphoma, mantle cell lymphoma, chronic lymphocytic leukemia, and an overview of the hot topics in the field. Stay tuned until the end of the program, where Dr. John Winters from New England Cancer Specialists joins us for a discussion about how these data may impact community hematology oncology practice.
Hi, I'm Dr. LaCasce from the Dana-Farber Cancer Institute. Today I'll be discussing data presented at ASCO and EHA for marginal zone lymphoma, the emerging agents to watch out for, and some nuances that may impact CAR T-cell therapy for patients with non-Hodgkin lymphoma and other hematologic malignancies. Many of the resources we discussed during this program can be found on the Lymphoma Clinical Resource Center at www.exchangecme.com. So first, let's discuss frontline treatment of patients with marginal zone lymphoma. So there was a small ongoing study that was presented looking at mosunetuzumab both in untreated follicular lymphoma and marginal zone lymphoma using fixed duration mosunetuzumab. And this study showed, not surprising, high complete remission rates of 77% in 27 patients with high rates of MRD negativity. In the study design here, patients who did not achieve a complete remission were then treated with obinutuzumab and polatuzumab, and the 3 patients who went on to receive this therapy, given their inadequate response, appeared to do quite well. This study is small with short follow-up, and I think using obinutuzumab after a bispecific CD20 antibody, I'm not sure how much that strategy really adds to the polatuzumab, but overall there aren't a lot of studies, unfortunately, that include patients with marginal zone lymphoma, and this is one that I think was quite interesting. So now I just wanted to mention a number of the emerging agents that we're seeing in the treatment of non-Hodgkin lymphoma. And there are a lot of new mechanisms of action. So there are BCL6 signaling pathway ligand degraders. This is just really cool science where you can target proteins for degradation, including BCL6. There's also a casein kinase 1 alpha 1 degrader. We've seen some prior studies looking at CD47, and now we're seeing some new generation anti-SERP alpha and CD47 bispecific antibody with CD20. I think that's going to be a really interesting strategy. We're seeing the next bromodromain and extra-terminal protein inhibitors. We're looking at some NK T-cell constructs using the production and release of endogenous bispecific gamma delta TCR receptor invariant TCR positive natural killer like T cells. So it's a bit of a mouthful, but I think we're going to see a lot of novel therapies using NK cells as our cell to go after tumor cells. We're also seeing some novel bispecific antibodies, including a CD19 by CD3 T-cell engager. There are some new CD20 by CD3 bispecific antigens. There's a novel CD79B targeting antibody-drug conjugate. EZH2 has been a drug that has some activity in follicular lymphoma, and now there's a dual inhibitor of EZH2 and EZH1, which is being studied in early phase clinical trials. In addition, there are some novel BCL2 inhibitors that are in studies, and a number of interesting novel CAR T-cell products. So there is a CD19 BCMA bispecific bi-targeting or dual targeting CAR. We have a CD19 second generation CAR T-cell. ROR1 is a target we know that may be important in multiple subtypes of B-cell lymphoma, and there's a CAR targeting ROR1. There is a CD20 and CD19 dual targeting bispecific construct. In addition, there's a novel CD22 directed CAR T cell and newer CD20 CAR T cells also. So in thinking about CAR T cell therapy, we've really seen some amazing progress in our ability to treat relapsed and refractory patients. However, we still are learning how to optimize CAR T. And one major issue is how do we overcome T cell dysfunction in patients who have received therapies that may affect their T cells, or patients who have underlying diseases like CLL that certainly impact on T cell function. We have seen some products that have issues with manufacturing failure, either not enough T cells or T cells that aren't functioning properly. There's been a lot of work to try, we really need to be able to figure out who are those patients who are really going to benefit from receiving CAR T cell therapy. There's an emerging literature on secondary myeloid malignancies after CAR T cell therapy, which is always something that we worry about. CAR T cell therapy is very expensive and not available everywhere, so there's been a lot of work ongoing about cost and health resource utilization. And then lastly, logistical challenges associated with CAR T cell therapy. So let's look at some of the studies that were presented at ASCO and EHA that address these issues. So in terms of manufacturing failure rates, there were studies that showed this occurs in 1 to 13% of patients in clinical trials looking at CD19-directed CARs in relapsed and refractory large B-cell lymphoma. Factors that predicted out-of-spec products include older age, advanced disease, extranodal involvement, and a high international prognostic index. Not surprising, patients who require a second apheresis had worse survival, and the outcomes of patients who received out-of-spec products are not well described, but failure to manufacture an eligible product is clearly a barrier for patients with large B-cell lymphoma to receive CAR T-cell treatment. So one of the ongoing challenges in the CAR T-cell field is trying to predict which patients have efficacy at the individual level, but also trying to predict what patients are going to have severe toxicities. And the Europeans have put together this CAR hematotoxicity score, which is a somewhat complicated score that includes blood counts, CRP, ferritin, and assigns patients with a score of 2 or higher as being high risk. And what they've found when they use this score is that it does predict patients who have a high score are much more likely to develop what they have termed as the immune effector cell associated hematotoxicity. Patients who had a high CAR hematotox score in this particular study had a 6-fold higher risk of experiencing late immune effector cell associated hematotoxicity of grade 2 or higher, had lower overall and complete response rates at 90 days, lower overall and progression-free survival at 1 year, as well as a 3-fold increased risk of mortality. So there was data looking at patients developing secondary myeloid malignancies. There was a single center retrospective review of patients who underwent CAR T, 87 patients, where 6.9% of patients developed 2 MDS and 4 AML with a median time to onset of 14.2 months. There was another single center retrospective study of patients who received CAR T for non-Hodgkin lymphoma with a 3.7%, 7 out of 190 patients developing a secondary myeloid malignancy, and the median time to development was 29 months. There was another much larger cohort of patients who underwent CAR T-cell therapy for both relapsed and refractory aggressive lymphoma and multiple myeloma, 246 patients. 8.5% of patients developed a secondary primary malignancy, 52% were skin cancer, 33% were hematologic malignancies, and 14% solid tumors. So I think when we first started doing CAR T, a lot of these patients, at least with diffuse large B-cell lymphoma, were patients who had undergone prior autologous stem cell transplant and received many, many lines of therapy. And when you give patients lymphodepletion that includes fludarabine, I think none of us were really surprised to see some patients ultimately developing a secondary myeloid malignancy. I think what's going to be really interesting to see is in our patients who are less heavily pretreated, do those rates really decrease significantly, or is there something in addition to the lymphodepletion that may be contributing to the development of secondary MDS and AML? So there was a study that looked at the Transcend NHL 001 study to look in mantle cell lymphoma, to look at healthcare costs incurred by patients over the first 12 months after liso-cel infusion, including non-ICU hospitalizations, and looking at all of the data on what drove the cost. And the non-ICU hospitalizations were the largest driver of liso-cel-related cost in this cohort of patients treated with liso-cel. Most of the burden was incurred within the first month of treatment, with dramatic reductions in healthcare-related costs thereafter. And the primary cost driver was facility use, so inpatient stay and ICU admissions, which accounted for 83% of the first month costs and 78% of annual total costs. So these results suggest that treatment in the outpatient setting, even for part of the process, so the lymphodepletion and then receive the cells, and then keep people outpatient until they have a fever or other complications, may be able to confer significant cost savings to our healthcare systems. So there was an interesting study that took healthcare providers and assessed logistical barriers to CAR T-cell, to receipt of CAR T-cell. And this was done in both the US and the UK, and they looked at the referral process. 86% of providers in the US and 92% of providers in the UK felt that the referral process was a challenge. Eligibility was also a significant challenge at 81 and 77%. This included pre-infusion logistical challenges like waiting for leukapheresis spots and bridging therapy, funding and insurance, and this was ranked as a significant logistical barrier in 75% of providers in the US and 60% in the UK. In terms of infusion monitoring and challenges, including out-of-pocket costs, healthcare capacity, and caregiver support, was a barrier identified in 72% of US and 63% of UK respondents. And then with regard to long-term follow-up, this was also identified as a significant barrier, 82% in the US and 64% in the UK. So this study really indicated that logistical burdens and challenges are associated with different stages of the CAR T-cell process, from getting approval to pheresing to treating and then long-term follow-up. And there is a substantial unmet need for patients with non-Hodgkin lymphoma. Readily available off-the-shelf therapeutic options like bispecific antibodies may help alleviate some of these logistical burdens and challenges. So I will say, the one thing about CAR T that was highlighted in this presentation was, it's really the majority of the burden comes within that first month when patients are receiving inpatient and in the early follow-up. And with the bispecific antibodies, obviously we're treating patients for much longer periods of time, and that in and of itself brings its own challenges. So in the largest study to date analyzing referral, apheresis, and production time in CAR T-cell patients, it was found that a prolonged time to apheresis was associated with worse overall survival and increased hematologic toxicity. And this possibly can be explained by the increased bridging treatment exposure, including multimodality treatments, along with aggressive disease kinetics and systemic inflammation. So there was a large European study of 392 patients from 11 countries that looked at patient-reported outcomes in CAR T-cell patients with hematologic malignancies, and found that CAR T-cell therapy is associated with considerable toxicity in the short term, but patients reported a relatively good quality of life. In general, for general quality of life, emotional functioning, level of pain and fatigue were similar or better than that reported in the general population. The highest percentage of patients in whom CAR T had a substantial impact on their everyday life occurred during the infusion phase, and this was 61%. A considerable proportion of the patients experienced anxiety regarding disease recurrence and progression, identified in 76% of patients, risk of getting an infection in 66%, and long-term adverse events in 59%. So we know that anti-CD19 CAR T-cell therapy has shown impressive therapeutic results in aggressive large B-cell lymphoma. And we still are debating, the lymphoma subtype, whether this is a major driver of efficacy. Are we looking at patients with transformed indolent lymphomas versus de novo diffuse large B-cell lymphoma? So there was a study that did a match comparison which showed higher efficacy with acceptable toxicity in patients with transformed indolent lymphomas compared to patients with large B-cell lymphoma who were undergoing CAR T-cell therapy. The median progression-free survival was significantly longer in patients with transformed indolent lymphomas compared to large B-cell lymphoma at 18.3 versus 3.8 months. 1 year progression-free survival was 56% versus for transformed indolent lymphoma versus 32% for large B-cell lymphoma. There was also a benefit in terms of overall survival at nearly 37 months versus 15 months. So now that we've reviewed some of the recent data from ASCO and EHA presentations, let's bring in Dr. John Winters, a community hematologist from New England Cancer Specialists, to see what he thinks about the data we just reviewed and what questions he has for us.
Thank you so much for reviewing all of this data. It seems like there's still, so many, questions to be answered in CAR T as it moves forward. I think in the community, we often our biggest challenge is just geographic. We're not doing many of these, we're not logistically carrying out CAR T cell, at least in our community. We're referring them to a quaternary center. And so I have a, sort of question surrounding, how do you view sort of overcoming some of the geographic barriers to CAR T? It seems like it's both not just location and cost and, patient willingness, but also there's a lot of regulatory barriers to bringing CAR T into the community. I think sort of unlike allo transplant, where you need very specific training and expertise to do it safely. I think many of us are now doing, I think, community physicians could learn to safely administer CAR T. It's just a matter of getting the apheresis done and, not having that infrastructure, and then also, being able to infuse it.
Yeah, I think in terms of the barriers, when we see patients coming down from a distance, when you tell them they have to be within the CAR T cell center, 2 hours from us during that first month, and they can't drive for 2 months, that's often a big issue for patients coming from a distance. We have resources to try to help people find places to stay, but that is something that's often a big issue for patients. With regard to being able to administer CAR T at smaller centers, I think the learning curve is very steep, but once you sort of get there, I think that it could be safely done. The issue is that it requires a huge team. So, our nurses, we have nurses who are very adept, where they're doing the ICE score multiple times a day. We have, our patients are cared for on a PA service. So the physician's assistants that we have are amazing. And, we have rotating attendings, and they're often the glue that really is able to make it a very safe process, because they see everything, they do it every day, and they sort of know when patients are going south. And I think that when we first started, there was a lot of trepidation, and we all did our REMS, and we were all very nervous, and we would send people to the ICU more readily than we do now. But you also need really good neurology backup, and our patients, when they get significant toxicity with CRS, we preferentially want them to go to the neuro ICU because we know what's often right behind the CRS is the significant neurotoxicity, and some of these situations can be very tricky with increased intracranial pressure, and you need to have neurosurgeon, rare, but when these happen, they can be really significant. So I think that for certain patients and certain products, like, Axicell is very reliable from a manufacturing perspective, and we use it a lot in our younger patients, but it is associated with more toxicity. Lysocell, on the other hand, has a much lower rate of grade 3 and 4, particularly neurotoxicity. So I think it could be done, and I think now that we have these great networks of the formal networks between the academic centers and our community practices, so that there's someone always available. You need that backup, because we have the backup available. We pick up the phone and page our friend and say, hey, what would you do in this situation? Because so you don't feel like you're kind of hanging out there without backup.
Yeah, it's interesting. It's like, I wonder how, if we could sort of start to take some of these pieces and put them back into the community to make it more accessible, even slowly. Like you said, the 2 months post CAR T, can some of that be done, after training, or but as you said, though, there's probably other infrastructure that we don't have, or experience that we don't have in the communities because we haven't been doing it.
And I think, the very strict guidance was put in place with the original CAR Ts, and I think, the 1 month being very close, maybe that, I don't know, maybe parts of that could be re-examined based on which product you're using, and we've garnered a lot of experience over time, and there are so many real-world publications looking at how CAR T has been applied more broadly. So I think we could learn whether, some of the things we do may be overkill, like how many times do we see someone readmitted for neurotoxicity at 4 weeks? Almost never. It just doesn't happen. So, I think that might be something to push back on the regulators about.
Excellent. Thank you.
John, thanks for joining us today, and I'd like to thank our learners.
Thank you so much, Anne, for having me.
Please remember to take the post-test and fill out the CME evaluation. Please watch our other ASCO EHA conference coverage videos, where I discuss latest data for the treatment of mantle cell lymphoma and CLL/SLL, and my colleague Dr. Ahmed reviews treatment of diffuse large B-cell lymphoma and follicular lymphoma. For additional CME opportunities, clinical resources, links to patient education materials, please visit us at www.exchangecme.com.